Let's finish our lecture on diabetes. We have gone through the review of the pathophys loosely and talked about the long-term effects of diabetes and really related those back into the benefits of exercise specifically for glucose management, and then also in the context of these comorbidities and the overall health benefits that come with exercise. At the end of the last lecture, we kind of laid in the next layer with exercise to keep in mind the different hormonal responses that are going on during exercise, to kind of come back and discuss some risks associated with exercising when you have diabetes. And at the start of this little subsection in the lecture, I mentioned that when a patient with diabetes exercises, both hypo or hyperglycemia are possible. Of the two of those, hypoglycemia is the big risk. The reason hypoglycemia is more common of the two risk profiles is because exercise increases glucose uptake. Exercise and muscle contraction is an independent mechanism to move those GLUT4 transporters into the membrane. So when you exercise, you take more glucose out of your blood. You do it more rapidly. And we already mentioned that a healthy individual would make up for that increased uptake by the liver increasing production of glucose to maintain plasma glucose within the normal range, at least until you hit strenuous, exhaustive exercise. So if exercise increases glucose uptake and a patient is taking insulin or an oral medication that increases insulin secretion, we now have two separate mechanisms causing increased glucose uptake, because the effect of insulin is to increase glucose uptake. So you have to think about the performance of exercise is an additional mechanism of taking glucose uptake, which would have the risk of taking too much glucose out of the blood and causing hypoglycemia. So you need extreme caution when prescribing exercise, specifically to diabetic patients who are taking exogenous insulin or oral medication that really increase insulin secretion. So this is the most likely of the two risk profiles. It can be extremely severe. The hypoglycemia can cause a patient to become unconscious and go into insulin shock. It is important to talk this through with a patient. A lot of type 1 diabetics have a very good handle on this relationship. They're very well educated about what their insulin does and what their glucose balance. But if it's not a patient that is as comfortable with that relationship, it's important to take the time to explain the fact that when you add exercise, you are adding a new path to take glucose out of the blood. So those individuals who are on insulin need to very carefully monitor blood glucose before they start, take a measurement during exercise to see how their body is tolerating it, and then after. Of the timing of the exercise, it is important to monitor blood glucose during the exercise, but really the greatest risk of hypoglycemia can be 6 to 12 hours after strenuous exercise. This is when muscle and hepatic glycogen is being restored. So for this reason, it is a greater risk to exercise in the evening, because this timeline of when the hypoglycemia might hit could be when they're sleeping. So if exercise is new to a patient and they don't yet know the amount of insulin related to the intensity of exercise, if they're not comfortable with that relationship, or if exercise is new, they should avoid exercising in the evening or use a lot of caution. If they exercise in the evening, they might need a bedtime snack or to wake up to do some glucose checks overnight. A lot of people who use insulin pumps have an alarm on that pump, which would wake them if they had the evening effect. Okay, so what are we watching for? We said we should instruct patients to check their blood glucose levels before, during, and after exercise. Hypoglycemia is when blood glucose is 70 mg per deciliter or less. So if they're able to check their blood glucose levels, that is the cutoff for hypoglycemia. If you are relying on signs and symptoms of hypoglycemia, there is a difference in how severe the hypoglycemia. Early, less severe signs of hypoglycemia are largely related to the sympathetic nervous system activation when blood glucose gets low. The sympathetic nervous system will release epinephrine with the goal of all of those glucose handling pieces of epinephrine. Remember, epinephrine will break down glycogen, stimulate the liver to make more glucose, decrease uptake everywhere else. So it is a good physiological response when blood glucose starts to dip to kick in that sympathetic nervous system. So the signs that we see are from an inappropriately high amount of sympathetic activation in relation to the exercise. So strong, rapid pulse, right? That sympathetic nervous system hitting the SA node and hitting the ventricle to beat faster and stronger. Skin is pale and sweating, vasoconstriction of all of those peripheral vessels, because the response, the sympathetic nervous system is vasoconstriction. They can get a headache. They can be kind of shaky. They can feel hunger. They can get symptoms of agitation, nervousness, anxiety. They might get tingling in their mouth and fingers and a feeling of fatigue and weakness. So these are early signs of hypoglycemia that would mean patients should be ingesting glucose. They need to get glucose into their body to restore their blood glucose balance. Later signs are more related to the symptoms of inappropriate amount of glucose being delivered to the to the central nervous system. So the central nervous system relies on glucose. The central nervous system does not have the processes of beta oxidation, so it does not use fat as an energy source. It needs a constant supply of glucose. That's why the blood supply is so critical, and even short-term interruptions of blood supply begin the processes of cell death in the central nervous system because of this constant need to deliver glucose to those cells. So as hypoglycemia goes on, the symptoms that get added to the list are all, if you put in your mind for studying purposes, think about the central nervous system not being fed enough. What would those signs be? Headache, blurred or double vision, drowsiness, lack of mental acuity, confusion, seizure, loss of consciousness, coma. So very much brain symptoms that we are seeing as hypoglycemia is later. What do you do if they take their blood glucose and it's less than 70, if they're having symptoms of hypoglycemia? If they are awake and able to eat, they need to eat carbs fast. And you should have every PT clinic should have some form of sugar on hand. Fruit juice, I have a bunch of these listed in your notes for you. Honey, hard candy. Some people have glucose gels that they can give patients. So when you are on your clinicals, make sure you know where the sugar is in the building so that if it comes to it, you know where it is. If the patient loses consciousness, they need medical attention. So this would be a medical emergency. But let's avoid this from happening in the first place. So it's important to talk to your patients about the risk of exercise causing hypoglycemia, but there are things you can do to limit that risk. One is if they do insulin injections, to not use the exercising limb as the site for that insulin injection. That is going to be the muscles that are already taking up a lot of glucose. Don't use that as your injection site. The best place if you're going to do an injection is an abdominal site. Balance out the exercise with an increased consumption of carbs. If they're not quite sure how they're going to tolerate it, have a small snack before to help buffer that increased glucose uptake, and then have carbs readily available during and after exercise. They can take what is that called? The GU that the marathon runners take. They can take that during exercise or have a juice drink during exercise to help balance out, knowing that we've just added a new pathway to take glucose up. And if they're using insulin, this is only going to increase. So I'm just pulling this slide back up as a reminder. We talked about in PathoPhase a whole host of endocrine disorders. And a lot of those endocrine disorders are treated by taking exogenous hormone. And we said, but there's always side effects to that, and it's never perfect because our hormones are regulated by this careful negative feedback. So our body gives us just what we need. So when you have a normally functioning insulin system, one of the effects of exercise is to suppress insulin secretion, because we don't want that additive effect of two pathways both working on increasing glucose uptake. So when our body has this independent mechanism for taking glucose up, it suppresses insulin down and raises glucagon up. When you are taking exogenous insulin, there is no suppression of that hormone. The hormone stays at the level of the injection, independent of the physical activity or changes in diet. So it's on the patient, or in a lot of cases now, the feedback loop from the pumps, it is on the patient to regulate changes in glucose intake with the exogenous insulin they're taking. It's on the patient to regulate the insulin they're taking when they're going to be exercising. One concept related to hypoglycemia that I want to put on your radar is hypoglycemia unawareness. That is, the patient has physiological hypoglycemia, but for a number of reasons, it fails to cause that epinephrine secretion. So the symptoms of hypoglycemia related to that big CNS reaction are absent. Without that subjective feedback, that their body talking to them with the heart palpitations, the sweating, the anxiety, feedback that their body gives them normally that lets them know they're low, if that's not there, the patient would not know that they are low if they haven't physically checked their blood sugar. This is very dangerous because it can mean there's no warning until you get to late hypoglycemia, where suddenly the central nervous system isn't getting enough sugar and you become unconscious. This is why it is encouraged to actually take blood sugar and not just rely on the patient's subjective explanation of how they're feeling. The type of patient that's more likely to have hypoglycemia unawareness is someone with type 1 diabetes that has had the disease for a very long time. Their body kind of gets used to these episodes of hypoglycemia and they don't get as much of that sympathetic response, and that can be dangerous. As it says in your notes, antecedent hypoglycemia, if they've just recently had an episode of severe hypoglycemia, the next time they go low, they might lack a lot of those early symptoms and warning signs. So that's an important thing for patients to be aware of. If they just had a negative episode, that now they're at risk, they might not have as much signs. Exercise can be a cause because you're already kicking your sympathetic nervous system in, that it might not give them the same feedback as like a resting hypoglycemia episode. But a really big one is autonomic neuropathy. As you guys know, the nerves in a diabetic patient are very vulnerable to damage. And we talk a lot about the sensory neuropathies. That's the big cause of wounds in the feet that go unnoticed, that can cause all of the problems with the feet that we went into a lot of detail in PathoPhys. There can be motor neuropathies. That's one of the main causes related to some of the deformities in the foot. When you fail to be able to activate the intrinsic muscles of the feet normally, it can lead to a lot of these foot deformities. There can be neuropathies of the autonomic nervous system. So if you have neuropathy of the autonomic nervous system, the nerves that control our automatic responses in our body are going to be impaired. So some signs to be aware of a patient who has autonomic neuropathy. This may or may not be something that's diagnosed that you would know about. So if someone has diabetes, especially if it's a more severe form of diabetes and they have other neuropathies, you'd want to really be on guard for autonomic neuropathy. But some signs would be resting tachycardia. So heart rates greater than 100 beats per minute at rest would be abnormal. That would be a sign that the autonomic nervous system isn't regulating the resting heart rate very well. Postural hypotension is a very common sign of autonomic neuropathy. When a patient stands up, they get dizzy, they might even pass out. If you give them an exercise stimulus and you do not see that nice correlation of an increase in their heart rate response, so if there's a failure of the heart rate to increase in response to exercise, that is a positive finding for autonomic neuropathy. They might have an excessively high blood pressure response to exercise. These are all potential signs that might give you a window into a failure of the autonomic nervous system to be functioning normally. If a patient has autonomic neuropathy, they might not have the response to the plasma glucose to give the signs of hypoglycemia. In your notes, I had, just because this is the place to talk about it, I just want to give you a couple other things to kind of put on your radar for autonomic neuropathy. We mentioned the first one. Chronotropic incompetence is the name for that blunted heart rate response. You increase exercise intensity and there's just no change in heart rate. That is abnormal. An impaired blood pressure response or an exaggerated blood pressure response. Silent ischemia is kind of a scary one. So ischemia would mean that there is a mismatch between oxygen supply and demand in the heart. And hopefully at this point, you guys know of the signs that somebody is having an ischemic episode, whether it's chest pain or burning or left arm and jaw pain. Those are all the feedback to give you the warning bells of, I have exercised this person beyond the blood flow to their heart. Something is wrong here. If there is autonomic neuropathy, there might not be that sensory feedback. So they're not going to feel chest pain or jaw pain or left arm pain or burning gastrointestinal disruption kind of feeling. The lack of the sensory feedback, and then if you add in the high rates of vascular disease, cardiac ischemia is, if you compare to the general population, much more common in diabetics. So it can be really challenging and a little scary. So if patients have autonomic neuropathy, it would be recommended that they get some kind of a screening of their cardiovascular response to exercise before beginning exercise. So having a graded exercise test or getting a referral back to their MD to be cleared for exercise, because the normal signs that will give you that feedback would be missing. If somebody is having silent ischemia, they can have some evidence of it, although there can be nothing at all. But there is something called the anginal equivalent. I'll just write that one down. Whoa, where'd my pen go? So angina equivalent are signs that we know are suggestive of ischemia, even though they aren't typical angina signs. So dyspnea would be one. That's, the difficulty labored breathing. That would be if they're exercising and they're suddenly having dyspnea, you should stop exercise and report that back to their doctor. Diaphoresis can occur, that's increased sweating, and then orthostasis can be a sign that they're having, that's actually a sign likely of starting to get reduced cardiac output. So then they're not maintaining their pressures and they become dizzy or faint or lightheaded. Those can all be equivalent messages of angina when someone has autonomic neuropathy. So something to put on your radar. Some other things that are that you might see if somebody has autonomic neuropathy is poor thermal regulation, because that's all through the autonomic nervous system. They might have a reduced thirst sensation, so that can increase the risk of dehydration. So if they're exercising in the heat, they might not get that trigger to drink. They can have anhidrosis, which is a lack of sweating. Those are all potential things to see with autonomic neuropathy. So the other side of the coin is that hyperglycemia is possible. The cutoffs here are a little more vague than hypo. It would be unlikely that a patient would have any symptoms until blood glucose levels were greater than like 180 or 200 greater than 180 to 200 mgs per deciliter, but it can get much, much higher than that. So let's just first address this. How is it possible? Like, doesn't exercise take glucose in? Didn't we just fully explain why exercise is so likely in this population, not so likely, has this increased risk of developing hypoglycemia? How on earth is the opposite possible? The first is that in general, in diabetics, plasma glucagon is typically elevated. And this is much more common in type 1 diabetics than type 2. The reason that plasma glucagon can be elevated is that insulin normally inhibits glucagon release. That's part of the reason they work so well as a yin and a yang. You know, insulin gets released in a normal, healthy individual every time plasma glucose goes up. And at the same time that insulin is getting secreted, the insulin helps to block the glucagon release. So when there is a lack of insulin, you kind of take the brakes off of glucagon. Well, if you have kind of resting high glucagon, what does that do? Well, glucagon stimulates gluconeogenesis in the liver, it stimulates glycogen breakdown, and it stimulates fat breakdown. So this elevated glucagon is going to help to contribute to more glucose in the blood. Then, when you exercise, you get this hormonal response. We actually see glucagon go up even higher, which would facilitate the plasma glucose numbers. With exercise, we see an epinephrine release. Epinephrine, again, helps to break down glycogen, stimulates the liver to make new glucose, and it blocks glucose uptake everywhere. So with epinephrine in the blood, it's going to facilitate more glucose being delivered to the blood. So when do you see more epinephrine? At greater and greater exercise intensities. So you can see an increased risk with increased exercise intensity. The third one on the list is cortisol. Cortisol works to stimulate glucose production, block uptake, all these things to help increase glucose in the blood. Growth hormone can spike, which also works to get more glucose in the blood. So with exercise, there's this hormonal response that is all working together to increase blood glucose. So it is possible that the response to those hormones, especially if the exercise itself isn't taking up that much glucose, can be a hyperglycemic response. I want to make one clarification because I think the way I said it might have been confusing. I mentioned in the very first point that plasma glucagon levels can be elevated, and I said it's more common in type 1 diabetics, which is true. That the resting glucagon thing is much more common in type 1 diabetics. But on the whole, when you put the whole thing together, and the risk of developing hyperglycemia during exercise, a hyperglycemic response to exercise is more common in type 2 diabetics than type 1. It is not a sure bet. Both could happen in either. But this is more likely in type 2 that are hyperglycemic anyway, and then they're adding the hormones and blood sugar spikes. I just realized that by making that point about the resting glucagon, I didn't want you to be kind of all in your head with just type 1 here. Okay, so let's talk about the symptoms of hyperglycemia. So the high blood sugar is going to stimulate thirst and polyuria. This is because this glucose load is going through the kidney, and the kidney cannot reabsorb all that glucose. So glucose is ending up in the tubules while you're making your urine, and it's pulling water towards it. Glucose is an osmotically active particle, so it's pulling water towards it, which means you're creating more urine, peeing out more urine, and losing water. So if you're hyperglycemic while exercising, dehydration is possible because the glucose that's being trapped in the urine is pulling fluid with it. What is the impact of dehydration on exercise performance? If you have less volume, because you're peeing the volume out, you're going to have a reduced venous return. If there's less blood in the heart, you're going to get a reduced stroke volume. How is your body going to maintain cardiac output if it has less volume? Cardiac output is heart rate times stroke volume. The only card your heart has to play is increasing heart rate. So if the dehydration is reducing stroke volume, if you want to maintain the cardiac output and be successful in your exercise, you have to do it with an increased heart rate. Your heart is working when it's beating. This is an increased myocardial demand if you're maintaining cardiac output with higher heart rates. This is a huge risk for this patient population because they are also more likely to have vascular disease, the potential for silent ischemia. If this is causing a mismatch, it can get dangerous quickly. So drinking enough and making sure that the patient is aware of their glucose levels can be really, really important. The other thing you see with dehydration is worsening of their thermal regulation. If you don't have the volume to utilize evaporation as a cooling mechanism, you're going to be worse at regulating your thermal status. All right, other signs are weakness, dry mouth, kind of goes with that dehydration, tachycardia, using heart rate to maintain cardiac output, hypotension. If you don't have enough volume and you're not maintaining your pressures, hypotension, fatigue, and confusion. What we have described so far is really the symptoms of hyperosmolar hyperglycemic state, where you have this hyperglycemia, which is creating the osmotic diuresis, causing the symptoms of hyperglycemia. It is possible to, when you're in this state, to develop ketoacidosis. It's much more likely if a patient is a type 1 diabetic to go on and develop ketoacidosis. And if you remember, the difference is that with the absolute lack of insulin, you're more likely to have this increased reliance on fat breakdown and get more free fatty acids and start kicking out those ketones, as opposed to a type 2 diabetic where they'll have plenty of insulin that is helping to block that effect. So if someone is having a hyperglycemic response to exercise and goes into ketoacidosis, the signs that is happening are the signs of hyperglycemia that we already listed, plus signs of that acid buildup. So nausea, vomiting, abdominal pain, shortness of breath, and then that fruity scented breath. That's you can actually breathe off the acetone of the ketones and you can smell it on their breath. Typically, when someone goes into ketoacidosis, they lack some of these kind of the more severe signs of hyperglycemia. So the fruity scented breath is from the acetone. The shortness of breath is because their body is producing a ton of acid. And your lungs are the secondary buffer to help blow that acid off. Because if you can exhale more CO2 than your body is producing, you can blow off that acid and try to get your body back into a pH balance. They won't be able to fix the problem, but that becomes a cycle of shortness of breath. So let's talk about where this ketone body formation comes from. So acetyl-CoA is formed through the process of beta oxidation and can enter the TCA cycle. And the way acetyl-CoA enters the TCA cycle is oxaloacetate was formed in the previous cycle. These two can come together and go through the TCA cycle. Let me just make that kind of an arrow here. So when acetyl-CoA shows up, if there is oxaloacetate available, it can join the cycle and go all the way around the curve, ultimately making, by the end, another oxaloacetate, which is why the cycle is a circle. So we said acetyl-CoA is one of the things that we get off when we do beta oxidation, one of the byproducts of beta oxidation. It's how we strip those two carbons away. So in beta oxidation, you have fatty acid that gets activated right first to acyl-CoA, and then it goes through the processes of beta oxidation, and you end up with acyl-CoA minus 2 carbons. And the 2 carbons are the acetyl-CoA. That's where they go, and they float over to the enzymes of the TCA cycle. So in the very beginning of our macronutrients talk, we said fat burns in a carbohydrate flame. And the reason that expression is in place is because when you have plenty of glucose around, glucose is going through glycolysis out in the cytosol, becoming pyruvate. And pyruvate is ultimately becoming acetyl-CoA, which also joins the TCA cycle. So we have these parallel pathways going on. If you are in a state of low glucose, if your body doesn't have enough glucose and the liver needs to make new glucose, it needs carbon molecules to make glucose. And one of the places it gets that from is it steals the oxaloacetate. It can take this guy and say, I'm going to use this for gluconeogenesis. I'm going to take this OAA and actually turn it into a glucose molecule. So in a situation of low glucose, oxaloacetate can be redirected out of the TCA cycle and used for the formation of new glucose. So when there is a greater reliance on fat breakdown over the use of glucose, or there's insufficient glucose, This beta oxidation is pumping out acetyl-CoA. And acetyl-CoA is showing up, floating over to the enzymes of the TCA cycle. But if there is no oxaloacetate for the acetyl-CoA to join, the acetyl-CoA cannot enter the TCA cycle. And in that case, the acetyl-CoA shows up and there's no oxaloacetate to allow it to go into the TCA cycle. It gets redirected into ketone body formation. So when we are relying more on fat than on glucose, we will overwhelm the TCA cycle with acetyl-CoA and start pumping out ketones. Ketones are acidic. If ketones accumulate, you could develop ketoacidosis. This is just a textbook image of that same idea, that when you are relying on fats and you have insufficient amounts of glucose, the oxaloacetate will be redirected into gluconeogenesis, and the acetyl-CoA that shows up will be unable to enter the TCA cycle and will be redirected into ketone formation. So there's this great interdependency on these pathways, and then we have a backup system. If we are using fat more and we have insufficient glucose, ketones can be used for energy, and the central nervous system can actually use ketones for energy. So this is an important safety valve in our system. The problem is, in the case of diabetics, the management of glucose is so impaired that they can get into trouble by using this safety valve as a primary form of energy metabolism, and the acidic nature of the ketones causes ketoacidosis, which is a serious condition that gives you those symptoms that we just talked about of ketoacidosis. All right, so when prescribing exercise to patients who have diabetes, the timing of exercise is really important, both how much food they're eating related to exercise and when they're taking their insulin. So because both exercise and insulin can increase glucose uptake, it's important to think through all three of those components together. So thinking about the timing of exercise can help prevent hypoglycemia. Patients may need to change when they do their insulin injections, or change the dose based on their exercise. They might need to time the eating of carbohydrates. If patients are taking blood glucose measurements before exercise, and I have a whole chart of some of these decisions on the next page, but if their glucose levels are low, they'll likely need to ingest carbohydrates before they start exercise. And then just keeping the time of day in mind. So early in the morning, we typically have higher cortisol levels and lower insulin levels. Because of that, that would mean it's more likely that you will have more glucose in your blood when you exercise in the morning. So if an individual is used to exercising in the afternoon and they kind of know their intensity and how much their blood glucose normally drops during exercise, if on a random day they're like, I'm gonna get up tomorrow morning and do my run, like early in the morning, even before I have my breakfast, their cortisol levels would be higher and they would have lower insulin. So at that time of the day, there might actually be an elevation in blood glucose instead of their expected drop. The flip side of that is when you exercise later in the day, they're more likely to get lower blood glucose. So if they are a regular morning exerciser and they're like, yeah, my blood glucose doesn't drop too much when I exercise, it could be the higher cortisol and the lower insulin is somehow playing a role there. And then later in the day, that same exercise intensity, may result in a greater drop in blood glucose. So because our hormones have this circadian pattern every 24 hours, it's important to know that your body may respond differently to exercise at different times of the day. This chart, so this is a nice decision chart to have as a reference when exercising patients with diabetes. Basically, based on their blood glucose levels, it gives you kind of the options that you have. If they are hypoglycemic before exercise, they should not exercise, they should ingest carbohydrates. So exercise you would expect would lower blood glucose further. So if they're already low, you don't want to add exercise in. If they're on the lower side, they should eat prior to exercising. And it has a comment here of 15 grams of carb for every hour of moderate intensity activity. If they're anywhere between 100 and 250, exercise is fine. And yes, this is a pretty high glucose number, but again, you would expect the normal response to exercise to lower blood glucose. If they are kind of sky high, greater than 250, and on this chart, it separates the patients out to those that are on oral meds versus insulin. If they're more than 250 and they're on oral medications, try the exercise. Again, thinking exercise might lower their blood glucose. You try 10 to 15 minutes and you test their blood. If the blood glucose has risen in response to exercise, you stop exercise. If the exercise causes a drop, keep going. Exercise is working as an independent mechanism to take up that blood glucose, but recheck every 10 to 15 minutes. If they are sky high and taking insulin, they should be checked for ketones. Now, just as a little aside, I found multiple sources that say you should check ketones if this number is 300. But the ACSM guide suggests checking ketones when they are greater than or equal to 250 at the start of exercise. So if you have a different source other than the ACSM, this number here might be 300. I am using the ACSM as my guide for this course, and that is what all of our fit recommendations have come from. So that is why I am giving you guys the 250. But I just want you to know that this number in a lot of other sources is 300, and I don't know where the discrepancy is there, but I'm presenting the ACSM. Okay, so if they're high and on insulin, you want to check for ketones. If they're positive for ketones, you want to avoid activity because it can be possible that exercise will kick them into ketoacidosis. If they don't have ketones, then you just you use the glucose monitor and kind of see if exercise helps you lower that glucose, and you make those decisions based on blood glucose levels. So I like putting this right at the end because the second half of this lecture is kind of all the scary stuff, the things that can go wrong, the stuff you need to monitor and watch for. But I don't want you to be scared away from pushing these people to exercise and exercise at a higher intensity, because the higher intensity is better for glucose management, and a physically active life is so important for patients with diabetes because of the multiple comorbidities, the high prevalence of vascular disease, and how much exercise can give them. I mean, it is truly like a pill where the side effects are like extra good things for you. Here is a pill that lowers your blood glucose. Oh, it also lowers your risk of cardiovascular disease and metabolic syndrome and peripheral vascular disease. Here's this great pill, and here's the long list of side effects, and the side effects are all also really good. So if you can have the musculoskeletal ability to exercise, you can educate patients on how to do it safely. Exercise is medicine for patients with diabetes. That's a wrap, folks. I will see you in the next video.